All right, let's get started. Okay, so we left off with showing how a train of four can be a very valuable tool. It's not a perfect tool, but it's actually better than nothing. And I'll start showing you some of the new advanced equipment that's coming down the pike. Hopefully, we'll start getting some of that stuff here as well. If you look at train of four values, one of the things that you have to understand, if you just take a normal train of four, you don't do any tetanus ahead of it, but you actually just test a train of four, and you get 0 out of 4 twitches, that means pretty much that 100% of the receptors are blocked. Okay? When you go to 1 out of 4 twitches, that has a very substantial number of blockade of looking at 90%. 2 out of 4 is 85%. 3 out of 4 is 80%. And when you see actually 4 out of 4, that person can still be 70% blocked. And that should tell you that no matter how good the monitor is, the best it can actually monitor to value is a 70% blockade. If you get a 70% blockade right now, it would make it difficult for you to move. It would make it difficult for you to breathe a little bit. Okay? But if you're healthy, you could still do okay. Okay? Now, you're going to get nauseous from it because different muscle groups have different sensitivities. The diaphragm is the least sensitive of all to muscle relaxation, which means that you continue to breathe despite being partially paralyzed in other muscles. What you notice about people after surgery that are not reversed is that their facial muscles lose their ability to express. So you don't really see people crunching their eyes as much. You don't see people smiling as much at times. Not because they're not in pain, just that they're weak. And the biggest complaint that they have is they can't see. They'll open their eyes, but they won't be able to see. Okay? They say they can't accommodate their lenses, and because that they can't really make you out. They know you're there. They'll see that there's differences in color, but they won't be able to focus on you and say who you are. So that's a concern, to say the least. So that's one of the things that I always look for is if I see somebody with nausea and vomiting, I always check to make sure that they don't have any residual muscle relaxation on board, and as well check if the person's been reversed. What you see here is a classic example of what happens with receptor occupancy and twitch height. You can see the twitch height under an individual that's receiving muscle relaxation. All the way to 70%, the twitch height is completely unchanged. So that individual, even though they're getting more and more muscle relaxed, when you're doing twitch exams, you're not really noticing any difference. It's not until you get up to 75% where you start seeing that the twitch height begins to drop off rapidly, and it's almost like a reserve. So as long as you maintain a certain amount of receptors, your muscles seem to be able to function properly. The twitch height is basically a single twitch of electrical stimulus that you give in just every so many milliseconds or so many seconds apart. The train of four, of course, is the same kind of deal, except there's a little bit of separation in time. And eventually you see everything's normal, then you hit right around 75% again, and that's when you start seeing the train of four drop off. And this is what we give the ratio. The ratio of a normal train of four is 100%, okay, a ratio of 1. And as you drop it down with the actual last twitch in comparison to the first twitch, this one is at 70%, you're looking at around 95, and at 75%, you're looking at 0.75 difference between the first twitch and the last twitch. And as it rapidly progresses down to 90% occupancy, you'll see that you'll have one twitch out of 4, one twitch out of 4, or even 3, but you don't see the fourth twitch, which gives you a 0. Okay, so that's what we call the train of 4 ratio. Tetany will still show evidence that you have something, even at around 90% occupancy. Okay, so when people say to you, well, I gave tetanus, and then I gave a train of 4, and I saw twitches, I reversed. That's a big mistake. Okay, you cannot do that. If you give somebody tetany, what you're doing by showing you last week's diagrams, you're basically flooding the neuromuscular junction site with high amounts of acetylcholine. And it'll competitively push off the non-depolarizer temporarily. So when the next twitch comes along, it'll give you a stimulated response. But in reality, that person's still 90% adhered to by the competitive neuromuscular blockers. So as soon as the acetylcholine levels drop back to normal, it'll basically go to full muscle relaxation again. So that individual cannot be reversed or should not be reversed because the medications that you have right now are, the way they work is they're competitively antagonizing the effects. Now this may not be a problem in the future if we have some of the new agents that are coming out, which is like Sugamidex. Sugamidex is a great drug if it ever gets approved. It basically acts like a sump. It sucks up all the muscle relaxant into the core of the molecule and basically inhibits its activity. So it basically trades out the neuromuscular blocker, so the new site is again available for acetylcholine. It works very efficiently. Now, one of the things, I should have brought this nerve stimulator today, I just forgot about this morning again, is DBS. Okay? For many, many years, when I was doing a residency, one of the things that we noticed is it took a little bit of time to get a feel for what train of 4 felt like to us. The first, second, third, and fourth stimulus, you can see that there's differences. Okay? But if you ask 10 people visually would give you 10 different answers. And that was kind of a problem. Okay? So what they came up with was something newer called DBS, which is double burst stimulation. And they found that when you compared it with 10 people that are observing, DBS gave you a much better intraclinical variance. Okay? There was less variability between these people that are inspecting it. What DBS is, it basically takes 2 stimuli that are a little bit larger than normal, okay? And you will basically watch the first twitch, and then you just watch the second twitch for the twitch height, okay? If you have, and that gives you what we call the double burst ratio. So you have 50 hertz train of 3 repeated 0.75 seconds later by an identical train of 3. The train of 3 is so fast that it basically congels into 1. Clinically, it appears only as 2 twitches. It's much easier to observe and to detect fade. So it's much more useful for noting persistence of fade after reversal. You will lose the second twitch of DBS about the same time as you lose the third twitch of train of 4. So that's around 75–80% muscle blockade. So clinically difficult, unfortunately, to detect fade above the 0.7 recovery. So again, that individual could still be 70% blocked. So here's where the really important lesson is from this. If somebody gets, when you go to clinical, and this, I'm telling you, this is going to happen to you, because a lot of people don't understand this, okay? You get to clinical, and people will tell you, I don't reverse patients. And you ask them, well, why not? And they'll tell you, well, I see that I have a complete train of 4, so that patient should be okay. And if you ask them, well, what's the percentage of train of 4 that indicates that you have 4 complete twitches with no fade? And they'll scratch their head and not really know. Or it's even worse. Some people will say, well, it's actually 70% blockade, but that's still okay. In reality, that's not really okay. Okay? You should be better than that, and you should basically reverse that individual at that point. Now, if you have, I'll show you later what the regulations are on this, and we'll keep moving. All right, so here's your normal stimulation of train of 4, okay? And then you see the above, next to it is DBS. Okay, so DBS is a double stimulus. And here's what your response would be. So because it's a super maximal stimulus, it's a little bit bigger. See, when you actually look at the double burst and look at it electronically, what it's emitting 0.2 milliseconds of energy 3 times, and it basically stacks up the energy, and it gives you a hyperstimulus response, which makes it easier for you to read as a consequence. Okay? But it looks basically to you as a double burst with 2 twitches. And you can see this person has a normal twitch height, 1-to-1 ratio, and then you can see this person is now becoming muscle relaxed, and to the point that you can actually pick up all the way at 0.9, which is about a 70% blockade in that individual, fairly easily. What this graph is trying to show you is that train of 4 is actually not as sensitive. Okay, it's more difficult to pick up, versus DBS is actually a much more rapid upslope, so you tend to pick up where that individual is adequately reversed or not. The ideal curve would, of course, be a square block, but that's highly unusual. So the optimal level to pick up is when you reach 0.9. But still, what you're seeing in these individuals is that the maximum you can do with DBS is really around 0.8. Even with a train of 4, it's 0.8. Okay, but DBS seems to be a little bit better in sensitivity that you're showing that you have adequate reversal. Now, there's other things called post-tetanic count. Okay? And there's a lot of confusion when people work on this in clinical. What basically a post-tetanic count is that you take 50 hertz for 5-second tetanus, which is pretty painful. You would never want to do this on somebody who's awake. We call it the cattle prod, okay? Because that's what it feels like. If you don't believe it, do it to yourself or do it to a friend and then get punched. So either way, you'll feel the pain. Okay? The tetanus, after you, and we actually give, some people actually will give that when somebody's hypotensive to bring the blood pressure up. That's how painful it is. Okay, it's basically equivalent to about 5 milligrams of ephedrine because you induce so much of a sympathetic response. Anyways, it's followed by at 2 hertz or train of 4. Most of the time it's followed by a train of 4. So there's other forms of post-tetanic counts that are used clinically. There's 100 hertz or 200 hertz, which is very, very painful, followed by a train of 4. The higher the hertz, the more acetylcholine you're going to push into your neuromuscular junction. Okay? So you got to be sort of aware where, if you get used to a certain way, if you go to 100 hertz and you start seeing a lot of post-tetanic stimulation that you didn't see before, it could be that you've changed the actual device that you're using and you're actually putting in more hertz than you think you are. What it basically does is it shows fade response earlier than the train of 4. The greater the duration of tetanus, the higher the hertz, the more sensitive the degree of neuromuscular blockade. But it's really post-tetanic count should never be used at the end of the procedure. Where we use post-tetanic count is to measure depth of the blockade. Okay? Now this is what a hertz is. It's not an amplitude, it's cycles per second. So if I'm giving you a very high hertz rate, I'm stacking it up and making it more electricity going in here per second. Okay, it does not mean the amplitude. So, but the more stimulus the nerve gets, the more acetylcholine you're going to release. Okay? Every time you see one of these wave heights, it releases a quanta of acetylcholine out of that neuromuscular junction. So every time you get a new sine wave, you're going to create more acetylcholine release. So the more rapid the hertz, the more rapid the effect is going to be. So here's what you see. If you give this person a tetanus response, okay, this is your control. This is the person who's normal. And then after that, you should see a normal train of 4. So most of the time, it's a little bit elevated, more so. If you have somebody who is on a moderate non-depolarizing blockade, you'll see even the tetanus will show fade, and then you'll get a post-tetanic potentiation post-stimulus. If on the other hand you've seen the depolarizing block like succinylcholine, you will induce the tetanus. You may still see motion, but you don't see fade. And then you look at your actual train of 4, it's actually diminished, just like it was prior to doing the procedure. And what it basically indicates to you is where the receptor occupancy is at. And you look at your tetany down here, it shows you that it's a little bit more sensitive to how much receptor occupancy you have. Okay, this is what it's trying to make you pay attention to down here is the 50 hertz. If you give the 200 hertz, you tend to have a greater twitch response with weakness involved in the situations. So you'll see you'll pick it up the more hertz you use. Now the post-tetanic potentiation, which you see is in 50 hertz, 5-second tetanus followed by 4 train of 4. You can see 60% of receptors bound by neuromuscular blockade. So that tells you that you're reversing better. If you're at 100 hertz, you can pick up 50% occupancy. And at 200 hertz, you can actually pick up the 30 to 40% receptor-bound neuromuscular blockade. Now, why is that important? Should you use it for gauging a reversal? And the answer is really not. What we use it for is really for deep paralysis to estimate the time of recovery. Okay? If you have somebody, let's say you're doing an eye case, and the surgeon says, I can't have the patient move at all. And it's going to be a long eye case of 4 to 5 hours. You can do retinal surgery or something, okay? Or strabismus surgery or something where the surgeon doesn't want you to have the person cough or move at all. In that patient, you want them to be intensely muscle relaxed, and you cannot have the diaphragm move, okay? And like we showed you last week, the orbicularis oculi and the actual hand one, which is the adducens, cannot pick up very accurately the diaphragm because those tend to be more sensitive than the diaphragm. So what we do is we do what's called a post-tetanic stimulation count. When we give this tetanus to that individual, we should only see maybe one twitch if we're deep. If you see that person still has all 4 twitches, there's a good possibility that that person may have diaphragmatic motion. So you would give a little bit more at that point. If you give post-tetanic, because that would basically tell you that you have a huge amount of receptor occupancy, it's almost 100%. It's actually beyond 100%, but it's 100% at the diaphragm almost at that point. What you see, if you give post-tetanic and you only get one twitch, let's say with atracurium, that individual is going to take 45 minutes before you'll see even a 1 out of normal train of 4 without tetanus. Okay? So that person is very intensely blocked. If you were using becuronium, which is an intermediate acting agent, it's a little bit longer acting than atracurium, if you only saw one twitch height, you're looking at almost 60 minutes before the patient is going to be even reversible at that point. Now, why is that important? Because you got to gauge when you got to reverse somebody. If the surgeon's saying, well, I got an hour to go, and you got one twitch, and you're on Beck, you're not going to give any more Beck. You're going to hold off on it so you can get 1 or 2 twitches by the time you're finished, so you can actually reverse this individual. Okay? So Pavulon will see 1 twitch per tetanus. Okay, Pavulon will actually take 80 minutes prior to reversal to get 2 twitches. Rock, you'll get 30 minutes prior to reversal. Vecuronium, 20 minutes prior to reversal, you see 2 twitches. That's not the 1 twitch. The 1 twitch I was telling you about will be actually another doubling of that, so you're looking at 40 to 60 minutes. Okay? The atracurium is when I was saying at 1 twitch, it would be 30 minutes. At 2 twitches, you're looking at half that, which is around 15 minutes. Okay? So what we usually target for, if we want somebody adequately to be reversible at an end of a case, is we try to go for 2 post-tetanic twitches. That way we have somebody that we can reverse. If you know that the surgery is going to be 8 hours, okay, then you keep giving it so you're down to 1 twitch. So you got a long period of time between the time that you plan to awaken the individual, and so you don't have to keep repeating the doses all the time. Okay. All right, so here's what you get. This is an individual here that has gotten a very high dose of muscle relaxation. And you can see that they've been given the tetanus here, which is in the black, followed by a train of 4, and post-tetanic stimulation. And what you see in this individual is no response. That person is so intensely blockaded at that point that you're looking at, if it was atracurium you're at least an hour, maybe an hour and 15 minutes before you can even reverse that individual if you don't give anything at all. As time goes by, you will see that if you do post-tetanic, you'll start seeing one twitch for atracurium. At that point, you're looking at 30 to 45 minutes to reverse. When you see the two twitches come in, you're looking at about 15 minutes of reversal time. And then when you start seeing the person coming back with, you see a lot of twitches, this is what we call surgical block, in the sense that the reason we call it surgical block because you should only have normally two out of 4 twitches, and that's as deep as you should go most of the time. That's all you need. And there is absolutely no reason to go any deeper. If you need to go deeper, you can use the volatile anesthetic. All the volatile anesthetics will suppress the actual signal, okay, because they actually affect the neurons. Okay? So that's kind of important to know. Last night we were working out with a surgeon that took about 15 minutes to do an appendectomy, and we were really debating what we should do. We gave 200 milligrams of succinylcholine to intubate the guy and put him right into a phase 2 block, and he was a rapid, he had a lot of pseudocholinesterase because in literally 3.5 minutes he was fully back. Okay, so at that point, what I said, should we give the guy atracurium with this surgeon that's so fast? And we sort of talked about it for a little bit, and we came up with a decision. Let's use, in this case, it's pure gas. Let's just go with sevoflurane, nitrous, and we're going to go to high concentrations. We're going to go up 1.5 Mac of sevo because the guy's young, so we cranked it up. And noticed right away, as soon as we got up there, the patient didn't move the whole case. Perfect. The surgeon never complained. He was done in literally 8.5 minutes. If we'd given atracurium, what would you be doing? Staying paralyzed. And not only that, you then would be trying to reverse that person too early. Okay? You'd be trying to reverse somebody which maybe could not be reversed. Okay? And get yourself into trouble. So just learning that little trick that you can use the volatiles can make a really big difference. Yes? Sure. Because what you're doing is you do the face or you do the hand. Right. Okay. That's actually it's very sensitive to getting blocked. So what you're seeing is the diaphragm is still moving, and that's what the surgeon's complaining about. In that case, I would usually switch to the hand. Okay, and then see what the hand would have. The hand would mostly have 2 to 3 twitches, and then you would into more blockade that individual. Okay, but sometimes the surgeons are going to complain about everything. Yeah, well, maybe he's got one twitch in between his ears. Okay, so just sometimes surgeons are particular about that. When everything goes wrong or anything's not going the way it is, it's always your fault. It's always anesthesia's fault. Okay, it's just that you got to understand one thing: surgeons are a peculiar lot. Okay, they're under a lot of stress, and I do respect them. Okay, but at the same time, when they try to tell you to do something, you can be led into a path of getting yourself into trouble. Okay? I've had surgeons tell CRNAs that are in the room, give more muscle relaxant. Okay? And the person, unfortunately, doesn't have enough experience, and they give 30 milligrams of atracurium. Okay? And then the surgeon, as soon as the person gives it, they turn around, I'm done, and they walk out. Oops. And you fell for it. Okay? Now you're stuck for 45 minutes waiting there until the stuff wears off. And there's nothing you can do about it. You basically just stepped on a landmine. Okay? Now the question is, do you actually listen to them all the time? And the answer is you look at the situation and make a clinical determination is should you or should you not? And if you have a question about it, that's what the radio's for. You're here to learn. So might as well pick up the radio and say, hey, Dr. Nolan, come on in. I just need you to do a curbside. It's a little consultation. We'll talk about it. And I'll teach you that a lot of times you can get away with it just diving the person deeper with the volatile anesthetic, which is reversible. And does it take a little longer to come off? Yeah. But, you know, this guy that we were diving down deep, it took us an extra 5 minutes to wake him up because we had him so deep. That's okay. I mean, it's better than having the problem with reversal. I'd rather deal with that. That's easy to deal with. I just had to wait for them to spontaneously breathe and then just let them blow it off. Okay? But I've seen a lot of people get in trouble, and a lot of people in anesthesia, unfortunately, still equate a good anesthetic with a person not moving at all. Okay? And they worry about it all the time, that what will happen if the patient moves just a little bit? Yeah, well, you know, that's part of life. The person's alive. You're not cranking him down to death. So you will see intermittent movements and stuff like that. People always say that they're waking up. They're not waking up. Okay? When you're at 2% volatile anesthetic, okay, you know, with SIVO, which is 1 MAC, you're not waking up. You might move, but that means you're at that 50% mark. Okay? That's what MAC means. 50% of individuals with enough stimulus will move at 1 MAC. But it doesn't mean that they're going to wake up. It just means that they're moving to reactive to pain. Okay? It's a sympathetic response. Okay? So be careful about neuromuscular blockers. People use them too much, and they supplement it for bad anesthesia. Okay? It usually means that you're not deep enough. Okay? If you're starting to see movement. Okay? You really don't. But sometimes you're sort of forced in a bad situation. In anesthesia, you have not healthy patients. And that's what the muscle relaxants are made for people that are really sick, that are marginal, that if you dive them down too much with a volatile anesthetic, you crash them. Okay? So in that case, you sort of have to balance it. I have to muscle relax them and then keep them a little lighter with a volatile anesthetic and sort of accept that. But if you do that to a 21-year-old and you don't keep them deep, they will emerge. They will be awake, and they won't be able to move. And they won't be able to complain at that point. Okay? And that's really scary. That's something where you never want to be at. Okay? So if you anything, you know, you got something you learn over time is you've got to deliver the anesthetic drugs. Okay? You've got to deliver the amnestic medications and the analgesic medications. Okay? This, unfortunately, these drugs have no properties of amnesia, and they have no properties of analgesia at all. Okay? The intensity of block with post-tetanic potentiation to ensure elimination of any bucking or coughing in response to tracheobronchial stimulation, then you must have a zero response after a post-tetanic stimulus. That's if you want absolutely nothing. So, and it takes a lot to do that. At a minimum, you must have a post-tetanic count of train of 4 or less than 2. And what they show here is a response curve. Okay? With a post-tetanic count of 2 or less, the person had very little response at all. Okay? They still have somewhat of a response, but a severe response was this line down here, which is bucking and coughing and moving. As long as you were under a train of 4, a post-tetanic count of with a train of 4 with 2 or less, this individual basically didn't really move very much. Okay, they might have just moved their head a little bit or done something like that, but it didn't. They didn't really do anything bad. The severe response is where the person starts coming off the bed. That's really bad. Okay. Now, like, where would this be a really high-risk time to do this? Well, anytime the surgeon's working in the mouth, okay, and working in the airway area is very stimulating. Your body is made to react from anything that's really trying to enter into your mouth that shouldn't be going into your mouth, like a blade or if they're doing a bronchoscopy, you see very severe reactions. The way you can ameliorate a lot of that, of course, is local anesthetic, but if you're forced to having to do just a general anesthetic, you better have them really deep. Okay? A lot of us will also supplement and eliminate part of this problem by adding lidocaine into the trachea, which is LTAs. But if you're not allowed to do that because you have to monitor, if you're doing vocal cord monitoring, okay, and the guy's looking around there and removing polyps or something, you've got to get them really deep, or you've got to get them down to a post-tetanic count of 2 or less, which is pretty intense. And then what you have to do is, at that point, is this is not going to be a rapid awakening. And when you're finished, then you're going to have to wait and be patient till you get your 2 twitches back. The biggest mistake people make when they do this kind of technique, which is okay to do, is that they give the tetanus, and then they just go to train of 4. And then 3 minutes later, they do a train of 4 in the same spot. And they see 2 twitches, and they go, yay, we can reverse. Okay? And how could they? You know? The answer is what happened is that tetanus effect is still around. So what you thought was 5 minutes was maybe 2 minutes ago. And now you're just doing another train of 4 post-tetanic. And if you check the other side's got 0 twitches. That's the real side. Okay? Now, one of the things you always got to be careful in Naples, okay, or anywhere else, is before you start a case, or right after you put them to sleep, before you give the muscle relaxant, if you're going to dive somebody deep, check your train of 4s here when you start. I usually do that just to teach students something, especially people that look absolutely perfect when they're 70 years old. I had one student looked at me and says, Dr. Nolan says, why are you doing a train of 4? I said, watch. So you did a train of 4 on this 75-year-old lady, and she was intensely muscle relaxed. The student looked at me like, wow, Dr. Nolan, we didn't even give any succinylcholine yet. I said, and that's right, it's Botox. Okay? So Botox will kill your train of 4 as well. Yes? That's a very common misconception, too. People think that just because I give 1 dose of a neuromuscular blockade, that I don't have to reverse, okay, because it's such a long duration of time. The answer is it varies. There's different people that can metabolize medications differently. Okay? Some people will metabolize the medication very quickly, and when you check the train of 4, they have all 4 twitches, and should you reverse at that point? And my answer is you should half reverse. Okay, and I'll show you that in a minute. If you go with somebody who has all train of a little bit of fade, then you get full reversal. Okay? If you have somebody which you don't have the other devices, which I'll show you in a minute, then you should still give half a reversal dose. Okay, I think if you don't, you're opening yourself up for not only malpractice, but you may harm a patient. That's my biggest concern, not malpractice. But I'm telling you, if you go into a court of law and you've had a bad effect on somebody in recovery and they don't do well, they basically die or arrest from breathing problems, okay, and you didn't reverse, the expert will say that you didn't reverse and that's not within the standard of practice and that you killed the patient. And you might as well pick up the checkbook and start signing it because you have no defense. Nobody will come to your aid. Not even the experts on the other side saying you don't have to reverse. They won't, because the literature says you can't. Okay? Yes? There is a pain where you can say that, but only if you have the right monitors. And we don't have the right monitors here, so my answer to that is you have to reverse everybody. Okay, now if you have the right equipment, which I'm going to show you next, then you don't have to reverse once you identify that you're at least at 0.9. So you have a 90% recovery rate at that point. So you should be okay. Okay? The common misperception is that at 0.7 that everybody's okay. That's where the problem is. 0.7 is when you have a full train of 4. You don't know any better than that. Okay? Versus you really want to be at 0.9 to be safe. At 0.9 and above, the larynx is completely returned. Even if you vomit at that point, you're not going to aspirate. Okay? But at 0.7 to 0.9, you still might have weakness and have problems. So for that reason, I do reverse. I reverse everybody because I don't have the equipment here. Okay? I tend to, after I put them to sleep. Please don't do it when they're awake. Patients really won't like you. Okay? So do it after they're asleep. Okay? I tend to do it just to show students what it looks like when it's normal, so then you can gauge it. Okay? A lot of times we're moving quickly, so we don't see it. We don't do that. But I always do that ahead of time. Okay? And then I show them, okay, this is what happens when you give succinylcholine. The height just goes down in all 4. Okay? So they get used to seeing it. Okay? And it becomes nicer. The way we used to do it in clinical when I was training is we would actually put the actual the device, the accelerometer that measures it, okay, and you would put it on your oscilloscope, and you would actually watch the twitch height. It was really cool, and we actually would do the twitch height continuously during the whole case. And you can see as the muscle relaxant kicked in, you can see the slope go straight down. And then you can see the recovery rate come back. It's really nice. But it took another 5 to 7 minutes to set it up usually. And the surgeon's usually stomping around. And now we're in private practice. I can tell you, you better move fast. Okay? Speed is important. Getting the patients to sleep is important. And people get a little anxious, to say the least, when you start hooking devices and put electricity to them. They think you're going to shock them to death. So it's also kind of a thing you got to really explain to people. Okay, this is our severe responses that I was showing you before. All right, different agents will do different things. Okay, if you look at the post-tetanic count for time for recovery, the longer acting agents like Pabulon take a lot longer to recover, which kind of makes sense. The intermediate acting agents are all sort of stuck in between. They're all sort of together. So you do have differences in the intermediate and long acting in the sense of recovery time. Pabulon is very dangerous if you ever use it in your practice. It should be restricted to only the patients that you plan to keep intubated, in my thinking, because it's so difficult to reverse properly. Okay, and what we usually do is by the next day is when we actually will wake somebody up, and even then, there's a new ICU study done recently where they looked at the rapid extubation criteria, and they were seeing that a lot of people should have been reversed and never did get reversed, and they were getting extubated when they were still partially paralyzed, which is really silly. Okay, so if you're into the rapid reversal thing of 4 to 6 hours after surgery, then you should have a protocol in place where people are checking train of 4s. And what's the disadvantages of post-tetanic count? It's very painful and should not be used on an awake patient or one emerging because it's kind of cruel. In the late phase of neuromuscular recovery, tetanic stimulation may actually produce a lasting antagonism, okay, which is the problem. Testing then does not then represent other muscle groups, and so don't use it at the end of the case. You should never use post-tetanic count at the end of the case. In other words, you can think that the patient is reversed when they are not, which is what I was trying to point out. 50 hertz is considered standard, and above that you may cause fatigue in a non-paralyzed muscle or fade. Okay, so what you see in post-tetanic count is you give the tetanus in this individual. This is competitive. So you're going to see fade response right away. Okay, so here's your tetanus. Okay, you're going to start releasing large amounts of the actual acetylcholine molecules. Oops, sorry. I should have just waited. Okay, just got to be patient. Okay. You'll see the acetylcholine molecules will leave in large amounts. Okay, and they will bind and start causing this is for somebody who's 70% blockade. And then you start giving your tetanic stimulation. And you see the next part of it, it starts causing fade. Keep going. This is still the tetanus. See, this person's still showing you they're okay. And then once you do your tetanus, which is next, this is somebody with 70% blockade. Okay, there's your train of 4 now. You're going to get a hyperstimulated response this time. So you're going to get an elevation higher than you expect. Okay, and the next one is going to start showing certain degrees of fade. Okay, now the fade is going to be so late that it's going to be not even visible. So that's where the problem is when you do this post-tetanic stimulation. Okay, the next one is going to be the one's going to show a slight diminishment in numbers. See, that's where you can't see where the difference is. You can't see the difference. The only way you can do this is actually by using a device that measures that. So that's why, doing post-tetanic potentiation doesn't really help you to grade how much percentage of blockade you still have. Okay? So how do you assess if the muscle is adequately relaxed? Okay? Use of train of 4 DBS, 1 or 2 train of 4 or 1 DBS is adequate for most cases. That's your surgical depth. Okay? If you need intense blockade, then you use a post-tetanic count with train of 4. and you want to use 2 or less. Okay? Don't repeat for at least 6 minutes in between at the minimum. Okay, so once you do it, don't repeat it. Okay? If you know that the person is down to 2 block, 2, that's perfectly okay. So here's when, I think this is a nice little graph of when should you use it. Train of 4, doing induction. Okay? I use train of 4 right before induction, and just to make sure that I know where my tracheal intubation is at that point. I want it to go basically to 0 before I tracheally intubate somebody if I don't want them moving. Yeah, if then the patient is surgically, we want an intense blockade, then you do post-tetanic count. If you want moderate blockade, you use train of 4, and reversal, you want to use also train of 4. Okay? DBS is usually used at the end as well in reversal determinations and the recovery room. Okay? It's a little bit less painful. It's still uncomfortable, but you can check in the recovery room. It's just you just drop the hertz down a little bit so it's not so painful. But you can see that there is no reason to use the post-tetanic count at all after you make the determination the person doesn't have to be deep. You see, unfortunately, people will do what I just showed you, okay? What I was trying to show you here, let me just try to explain again, is that people will do at the end of the case, they'll say, well, you know, I want to see if the person has any fade, okay? So I'm going to give them an intense tetanus response, and then I give them the train of 4. And they'll explain to you, say, well, I see no fade after post-tetanic potentiation. And they'll say to you that the person's okay. But in reality, what it just shows you is that the person's still 70% blocked. It is no better than the train of 4. So what's the point? Okay? And the other thing that it fools you is at that point, you don't see any more fade unless you wait the 6 minutes or you go to the opposite side and do a train of 4. Okay? So please don't believe that. It's just not really effective in measuring the degree of fade by using tetanus. That's why I don't use it after intense blockade. There's no reason to. So the clinical signs of increasing block are diplopia, difficulty swallowing, inability to head lift, poor grip strength, decreased vital capacity, jerky movement, and diaphragmatic paralysis. That pretty much looks like a flopping fish. Okay? That's always a bad sign. If you do see that, that's really grossly, that person has too much neuromuscular blockade on board, and you're in a bad place. Okay? But that doesn't mean that if you have somebody with a sustained head lift, that they still don't have some muscle relaxation on board. The answer is still true that they have muscle relaxation on board. So what are the quantitative methods? Okay, these are the devices that I'm going to talk to you about, that if you want to go to the next place where you say, well, I'm not going to reverse, because I think it's dangerous. Okay, my answer is, you're right. It is dangerous not to reverse somebody that doesn't need to be reversed. Okay? Because you can actually cause more relaxation at that point. But I can tell you, from our standpoint clinically, it's extremely rare to cause that effect. Okay? You're more likely to get in trouble if you don't reverse. Okay? So if you want to be one of those believers that you want to say that you don't want to reverse, then you better get a piece of equipment like this to quantitatively measure the degree of muscle relaxation. Now, what I was telling you before was the mechanical myography. That's a gold standard. That's what we used to use. That's really hard clinically to use. The electromyograms, which is rarely clinically used, and the kinetical myogram is not reliable. The phonomyograph is a fairly easy device to set up, but there's a lot of problems with it. And then we're using now the acceleromyography, which is basically a accelerometer that's put on this fingertip that measures the movement of the hand during stimulus. This is the mechanical myographer. Okay, you can see it's not a joke. It's a device where you have to put it on the patient, and it takes a few seconds and still. This is really used more for studies done on neuromuscular blockade. The electrical myographer is a fairly nice device. You have the actual electrodes, but you can see it takes a while because you have to put all these grounding devices. Most people start freaking out when you start putting this many electrodes on them. They think that you're experimenting with them. So people can show much higher levels of anxiety. And when you try to put these up on them on pre-op, I've run into problems with people start saying, what are you really doing? And you know, I'm kind of not comfortable with this. And it's amazing how people don't if you don't see, they all know about EKGs, but they never see anything like this. So again, something that doesn't really work clinically too well. Okay, this is the Kinetico myography. What it basically has is a polymer sensor that is easy to install. Unfortunately, what happens with the sensor is it comes off at times. It'll slip, and then the machine won't give you a good measurement. Okay, so then this is the subtle myographies. This is what we're coming up with nowadays. This is a little bit easier to install. I know this is a more bulky initial one that they had, but they now have this new device that's actually very easy to install on patients. And they actually, for reference, will actually have a temperature thermistor. Why would a temperature thermistor be important? That's it? Perfusion, that's right. Okay, very good. So it has to do with the muscle will be more intensely relaxed if the person is cold, if the muscle relaxation is already kicked in. If it's cold before you start, then the muscle relaxant won't get there. So it depends. So it's always good to have your temperature thermistor on board to see what the heck's going on. Okay, what this is called the Toft, which is the Train of 4 device. Okay, and I'll show you a picture of it in a minute. So what you have to think about is, why do reversal agents cause a problem? Okay, if people are worried about when should you reverse and why are people worried about reversals? The reversal agents that we're using are anticholinesterase agents. Okay, and in the sense that they're inhibiting the effects of acetylcholinesterase. So in essence, you're driving the acetylcholine levels to increase inside the neuromuscular junction. The problem with that is that the acetylcholine molecule not only will compete for the acetylcholine receptor site and push off the competitive inhibitor, but the acetylcholine will also, in high enough values, will come back and bind to the presynaptic receptors and intensely cause a blockade because of that. Okay? So that's where the downside of giving reversal is at. Okay? So what you see normally is when you give somebody this a non-depolarizer. This is a non-depolarizer agent. You can see that acetylcholinesterase is breaking down the acetylcholine. Okay? And they're basically breaking this down. This is a person with 80% blockade, and you can see that their fade response. What the acetylcholine molecule is doing is it's coming out and decreasing values because it's binding to the presynaptic membrane. Now, what happens when we give reversal? Okay, the next part is reversal example. Now we give reversal agent. When we give the reversal agent, it's going to bind to this, the acetylcholinesterase enzymes, which are here. These are your acetylcholinesterase enzymes. Okay? So I'm going to give reversal. Reversal now is going to inhibit the activity of acetylcholinesterase. And now the acetylcholine is going to stay in large values inside the neuromuscular junction because it has nowhere to go. And it's going to rebind, and it's going to cause competitive pushing off of the non-depolarizing agent. And eventually you're going to see no train of 4. That's what the hope is. Okay, so that would be actually a good complete reversal of this individual. And now this person has adequate strength. Okay, that's the purpose of it. Now, what happens should you, controversy over reversal, is it safe to give no neuromuscular blocker for past 1 or 2 hours? Should you give it? Should everyone be reversed? When should you reverse? Does neostigmine cause blockade? What is the proper dosage? And can you really know who to reverse based on the train of 4 being 4 out of 4? Let's take a look. Is it safe if you give no neuromuscular blocker for the past 1 to 4 hours to not use reversal? That's the question you asked. And the answer is no. Okay? It's not safe. The studies that were done recently showed using an intermediate acting agent like vecuronium nitrocurium, they're using a single intubating dose with no reversal. On arrival to PACU, 16% of the patients had a blockade that would indicate more than 70% or 80% blockade. That's pretty serious. That's 16% of the patients. And of that, 90, which means that they have about 60 to 70% blockade, was still 45% of the patients. So almost 60% of these patients had inadequate reversal based on that study. That should tell you right away that's really not a good idea. Okay? Should everybody be reversed? Okay? In clinical anesthesia, mistakes and belief that train of 4 of 0.7 to 0.5 has been adequate recovery of neuromuscular function. However, studies show that the train of 4, 0.8 to 0.9 must be exceeded to exclude clinically significant residual neuromuscular blockade. So a train of 4 less than 0.9 may lead to impaired respiratory ability to maintain the airway and increase for regurgitation and aspiration. So, in other words, the devices that we're using right now are not adequate to figure out if you should reverse or not. Everybody should be reversed, okay? Because the best you can get is with 0.7. No train of 4 or post-tetanic stimulation can tell you adequacy based on this feel. As a consequence, you should reverse everyone unless you can prove quantitatively that reversal is greater than 0.9. So if you want to do that, I'm okay with that, but then you get a myogram. Okay? You get your devices and you put them on the patients and you monitor that. Be safe. Okay? You want to be treated like everybody else is going to get treated. Okay? So what happens if you don't reverse? If you have the train of 4 ratio of 0.7 to 0.75, these people will have diplopia, visual disturbances, decreased hand grip strength, inability to maintain incisor teeth at position. That's called a tongue depressor test, which means they'll bite on the tongue depressor and they try to hold it in their mouth and they can't. Inability to sit up without assistance, severe facial weakness. Speaking becomes a major effort. They'll look at you like, can't speak, okay? Bad sign, okay? And they have overall weakness and they're tired, okay? At 0.85 to 0.9, you still have the visual disturbances, the diplopia, and you have this generalized fatigue. This is the actual studies that were done. I'm not going to go into all this, but if you want to, you can actually look over this study. It's a really good paper that went all into this and reviewed it. The guy was up in Mayo Clinic that described this and went over it. And you can read the whole thing down here. It says Residual Neuromuscular Blockade Lessons Unlearned, Part 2, and read Part 1 first. Part 1 is the one that we talked about in the initial part, and then Part 2 is this one. Again, same thing, just shows you just the actual sensitivity and specificity of the different studies. And I'm not going to go into it. We don't have enough time. Okay. Clinical tests for postoperative neuromuscular recovery are unreliable. Okay. So if you hear that somebody tells you, well, I can do clinical assessment on somebody and I know that's reliable, the answer is really not. You can have sustained eye opening, protrusion of the tongue. All those things are really not good enough. Okay? You can have a total normal tidal volume in somebody that's still neuromuscularly blockaded. So just because they're breathing doesn't mean that they're reversed. Okay? Their airway still is not adequately reversed. So when you pull out the tube, you might find out that the person goes into what you think is laryngospasm, but what's happening is the cords are just closing back up. They can't stay open when you're trying to breathe in. So sometimes the reliability gets better when you do a head lift, but it's got to be at least for 5 seconds. So the person holds their head up and then drops it back down. That's not a sustained head lift. You've got to hold it for at least 5 seconds. Okay? And normal swallowing is also a questionable, reliable test. So when should you reverse patients? I wait till I get a minimum to a train of 4. That's personal experience. I've been burned enough times to never do it again. I will never do it again. I promise myself that every day. Okay? That if I see only one twitch, I sit. And I don't care who gets mad at me. Okay? I'm going to sit. If it's going to be a rush because we need to get this guy moving along, that patient gets put on a Diprovan drip. Out we go to recovery room, put him on the ventilator there, and then you bring the next patient back, and then let the doc take care of it, and he'll reverse the patient when he has 2 twitches back. Okay? So if you're in a rush for some reason to expedite things, then you bring the patient out and put him on all the monitors and put him on the ventilator and make sure that he stays sedated. Okay? It's really better to wait till you're at least 3 to 4 twitches. So if I see somebody that I gave something like Pavulon, I don't reverse at 2. I will wait till I hit 3 because Pavulon is much more difficult to reverse. Somebody with atracurium, I don't have any problem reversing at 2. Rocuronium is very tricky. If you give reversal at twitch at 2, it sometimes is very difficult to reverse. So different agents have different difficulties in reversing. A lot of people don't use rock for that reason. Okay, it's tricky. The first time you use it for induction, it's not a problem, but you get a repeat dose of rocuronium, and all of a sudden it seems to saturate the neuromuscular junction, and you seem to have a really hard time competing and pushing off the rock. That's why I think Sugarmandex came about, because people started saying, well, you know, rocuronium is really not working the way it's supposed to. It's not being reversal. So most people went back to atracurium. Even though atracurium has the disadvantage of histamine release, it's cheaper and it's very reliable to come off. Okay. The recovery first basically starts when you have all trainophora present. Okay. Neostigmine takes time to work. That's the other thing. When should you reverse? And the answer is neostigmine is not a magical drug. It's like local anesthetics. I had a student last night who I was putting a spinal in with him, and she was kind of anxious because the last 3 spinals that she had put in with some other people, the patients were moving and squirming around. She said, well, you know, it seems like it was a very uncomfortable procedure, Dr. I said, well, okay, how do we do something like this? We put this patient up. We gave him 1 milligram of Versed, so it wasn't like we were oversedating the guy. Okay? I said, okay, take 3 cc's of local anesthetic, put 1.5 cc's in, 1.5 cc's inside the tendon sheath. Okay? We did that. And I said, here's the magical thing to do. And she goes, what's that? Wait. 30 seconds. Okay? She waited 30 seconds. I said, okay, now put the next needle in. The patient didn't feel it, didn't move, never felt anything after that. Put the spinal in. She got the spinal in. We did the procedure. Everything went great. She looked at me like amazed. Okay? Medications are not magic. Okay? They're not like a light switch. They don't just work immediately. It takes time. Some medications work very fast because they get there to the receptor via the bloodstream, so it takes them 30 to 40 seconds to work. But other medications take longer to penetrate into the tissue plane that you want it to work at. And one of those examples is the neostigmine. Neostigmine takes 8 to 9 minutes to work. It's peaking at 8 minutes. So a lot of people that don't remember this will reverse when the surgeon's putting the staples on. That doesn't make sense. Okay? The surgeon's already done. Okay? And you're giving reversal at that point. You give reversal 8 minutes beforehand. So when the surgeon is putting the stitches in the muscle, that's when you reverse. The person's not going to come back at that point. Okay? So sometimes it can take as long as 15 to 20 minutes for adequate reversal to take place. So you really got to sort of put this in earlier than you think. The duration of action is short. With these agents, it starts decreasing after 25 to 30 minutes. And so if you have a long-acting agent, you may get re-muscle relaxation again, which is not something good. Reversal is dependent on the neuromuscular blocker you're using. The long-acting agents are more difficult. The intermediate agents are easier. The easiest one to reverse is atracurium, and rocuronium is the most difficult to reverse. Neostigmine can also be can have effects when you have things like sevoflurane on board, other agents as well. Cisatracurium or rocuronium seem to be a little bit more difficult to reverse versus other agents. And the normal reversal dose for neostigmine, sometimes people will write down 0.04 milligrams per kilo. Most people will say about 0.07, but most people will put about 0.04 milligrams per kilo is usually what they're looking at. Okay? If you're looking at train of 4 to reach 0.9, what the studies were showing when they were doing the study was that it would take 9.4 minutes to get a train of 4. When they had a train of 4, it took 9.7 minutes to reach 90% reversal, which is great. Okay? But look what happens if you reverse at one twitch. It took 28 minutes for it to reach that. Okay? So even if you're giving reversal, if you're giving somebody reversal that is at one twitch, you're kind of really asking for it. You know, you're not going to reverse adequately, and even if what appears to be reversal is adequate, you're still not peaking effect till around 28 minutes. Okay, so be careful with that. I would recommend you keep it to at least 2 to 3 twitches before you reverse. So recommendations are the following. Okay, this is the things that are the take-home points. No neuromuscular monitoring or peripheral nerve stimulator, and clinical tests for adequacy of reversal is unreliable. So pharmacological reversal should be administered routinely. If you have a peripheral nerve stimulator, which is what we all have here, and you have train of 4 1 or no train of 4, then you don't reverse. If you got a train of 4, 2, or 3, then you get full pharmacological reversal, okay, which is either between 0.4 to 0.05 milligrams per kilo neostigmine with glycopyrrolate. Some people give the 1-to-1 ratio. I tend to give it by 1 cc less of glycopyrrolate, which is just my personal way of doing it. Train of 4 with fade, okay, if you have a fade of at least presence, administer pharmacological reversal, still full dose, okay. If you see no fade, which means that you have a train of 4 that may be exceeding 0.4, then I still administer pharmacological reversal, but I go low dose. I give half the dose. Okay? So everybody gets reversal, period. Okay? Now, if you have quantitative studies, this is where I think that I'm okay with this. Okay? This is the only time I'm okay with this. If you do quantitative studies and you do the TOF test, which is the actual accelerometer, okay? If you see no train of 4, 1, or none, then you delay reversal. At 2 or 3, then you give full pharmacological reversal. If you see fade, you still give full reversal. If you get no fade, okay, and your TOF is telling you that's between 0.4 to 0.9, then I give full pharmaceutical reversal, and then I may still consider low dose. But if I get a TOF of greater than 0.9, which is what the machine actually is telling me, then I don't reverse at all. That's the only time I would not reverse in clinical. If I had actually had a machine that actually tells me that my train of 4 is at 0.9, then I'm okay. Okay? That person is going to be safe. So can neostigmine cause blockade? It can for a patient who does not have any neuromuscular blocker on board because it causes fade in these situations. But it's really, the author in this writing says it's probably short-lived. And I would tend to agree with it. If you do cause a problem, it's not going to be very long. Okay? And the reason it's not going to be very long is because the acetylcholine is going to get eventually depleted. Okay? And then the train of 4 fade is going to go away. Okay? It's only temporary. It can be, you can see it in patients with a 0.9% recovery. If you can objectively monitor it, it may be safer to reverse. If you can't objectively monitor it, it may be safer to reverse. Much more dangerous if you have residual neuromuscular on board. I tend to agree with that statement. Mechanism is described in the following slide. Okay? This is a person who is at 0.9, and now you give full reversal. And here's the bad thing about it. Okay? When you give the full reversal, now what's going to happen is as the acetylcholine now comes out, it's going to stay in high quantities outside, and it's going to begin to block your presynaptic receptors. And that's going to inhibit the release of quanta of acetylcholine, so you will begin to get fade. Now the question is, how long will that last? And the answer is not for very long. Okay? Usually it's about 10 to 15 minutes. Just long enough to get you in trouble, but not long enough usually if you're supportive and watching the patient, it usually goes away. Okay? But that's the reason, the mechanism for why neostigmine can be a problem. Hopefully that makes more sense than what the book writes. Okay. Other problems with neostigmine is nausea and vomiting issues overrated. I really believe that people sort of play this game with you. If they don't want you doing something, they will tell you in clinical, it causes nausea and vomiting. That is the biggest BS line I've ever heard in my life. Everything causes nausea and vomiting. Okay? Shaking somebody's head causes nausea and vomiting. Moving a patient from one bed to the next, the gurney, causes nausea and vomiting. Okay? A patient who just had a meal is going to have a high risk of nausea and vomiting. Adding narcotic for pain is going to cause nausea and vomiting. Volatile anesthetics are going to cause nausea and vomiting. Okay? Reversal is going to cause nausea and vomiting. Pick your poison. Which one do you want to use? Okay? They all cause it. Okay? Surgical stimulation causes nausea and vomiting. Does that mean we shouldn't have surgery? Okay? My point being is, if you're worried about nausea and vomiting, give the antiemetics and prevent the nausea and vomiting. If you can try to eliminate an agent because you think that it may make a difference in that case, do so. But if you just take one medication and say, I'm never using nitrous, I am never using reversal because they cause nausea and vomiting, you are absolute silly. Okay? It does not make any sense to do that. Every drug has its bad side effects. Okay? Now, will it cause QTc prolongation? You may be concerned about it in long QT syndrome, yes. Will it cause a problem? Most of the time the answer is usually no. Can it cause bronchoconstriction? When you give it with anticholinergic, it seems not to be a problem. So, and would you ever give it without an anticholinergic? The answer is no. Okay, so it's not a problem. It can stimulate the salivary glands, yes, but when you give it with anticholinergic, you get the opposite of the effect. So you don't usually see that problem. It can cause meiosis, rarely. And it can cause an intestinal tone increase, which always makes the nurses very uncomfortable because the person has diarrhea all over the bed. So in that case, you sort of lose points for that. But okay, another downside of a medication. Okay? How do you know you're in trouble? If you get any of these symptoms, you know you're in trouble. What do you do in this situation? Here's what I do. I go through my algorithm. Patients showing signs of residual neuromuscular blockade. The answer is, did I reverse the patient or did I not? If I did not reverse the patient, okay, then I would reinduce and then usually reintubate, okay, that individual, okay. And when you have a train of 4, 2 or greater, then you reverse. Wait 15 to 20 minutes to make sure that your reversal is adequate. If a train of 4 with no fade, wean and extubate, and then transport to recovery room. That means you just screwed up. Don't leave without reversing. On the other hand, if you do have somebody reversed, okay, and now they're still showing signs of muscle relaxation, you then reinduce them and intubate them. Get it over with. It's just too painful to watch. And people try to get, I'm going to just watch them and ventilate them. And I'm going like, yeah, and they're remembering everything that you're doing, and you're torturing the poor individual. I've never seen anybody that's reversed that is not hypertensive and tachycardic. Okay, because these people are freaking out. Okay, they are awake internally, but they can't move. Okay, so just put them back down, put them to sleep, intubate them, sedate them, and go to recovery room and leave them intubated. Okay, and put them on a propofol drip. Okay, and then when that guy comes back with a train of 4, in an hour they'll check again. If the guy's okay, then they'll wean him and extubate him, and it's all done. Okay, it happens. It sometimes happens when you thought that you had adequate 2 twitches, but in reality you only had 1 twitch, and when you reversed, you just didn't have enough time by the time you pulled the tube out. Okay? And everybody feels the pressure of pulling the tube out, and you're going to make this mistake. Try to avoid making this mistake. Okay? I've learned the hard way, and you will learn the hard way too. So hopefully this will help you avoid some of that problems. The take-home message is, long-acting agents like Pabulon should not be used unless you're planning to leave the patient intubated. Residual neuromuscular blockade is not a benign thing, and tactile train of 4 should be used in every case. Avoid total twitch suppression in most cases, so keep the block around 1 to 2 twitches. Reverse your neuromuscular blockade when at least you got 2 train of 4, preferably if you have 3 to 4, that's even better. Use DBS after reversal. Okay? Lack of fade does not indicate adequate reversal. So when people tell you that, that's wrong. Inadequate recovery of postoperative neuromuscular function cannot be guaranteed without objective neuromuscular monitoring. That's the really bad side of it. Okay? Unfortunately, we need to have a better clinical device, which is the accelerometer, to exclude clinically significant neuromuscular blockade. So I'm trying to get that right now. I've actually called the rep at least 3 times. The rep doesn't call me back, so I'm not sure if the company's still working or doing what, but I'm trying to get a TOFT, which is the train of 4 device that will give you the ratio. Okay, and when we get it, I plan to put one in the simulator here, then we'll get one for each clinical site. So hopefully you guys will then get to use it and get to realize when people argue with you, this would be a great argument. You can have the argument, should I reverse or not? Put the TOFT on the individual, and then let the TOFT speak for itself. Okay? When you find out that the person is not adequately reversed and the person thinks they're adequately reversed, then who's won? The argument. Okay? So I think that's the next place I'm going to put this in. I'm going to put money where my mouth is and find out really how much degree of problems we're actually having in our clinical site. Okay, we'll give you guys a 10-minute break, and we'll finish up with anticholinergics today and be done for this exam